Welcome to the presentation of awards. The Student Paper Award goes to Alice Chen. She is engaged in research on how physicians respond to changes in Medicaid payment and eligibility. Her research has been published in the Journal of Health Economics. She also studies infant mortality in the U.S. relative to Europe, returns to Medicare expenditures, and the impact of health and leisure on measures of inequality. She receives her PhD degree from the University of Chicago Booth School of Business. She will join the Price School at USC as an assistant professor of public policy this fall. And I have a plaque for her, for Alice. The next awardee is Amy Finkelstein, who is receiving the ASHEcon medal. She is the Ford Professor of Economics at MIT. She has received numerous awards, including, maybe most notably, the John Bates Clark Medal, which is given to the most outstanding economist less than or equal to the age, less than the age of 40. Our award is given to the outstanding health economist less than or equal to age 40 in the year of the conference, which is January 2014. She has published extensively in major economics journals. Her work is probably on many of your reading lists as it is on mine. So I congratulate Amy. She also has a crystal plaque, but we're not going to bring the plaque out here.
Thank you very much. I am deeply honored by this award, and particular to be able to still claim to be less than or equal to 40 is going to be, I fear, a fleeting pleasure. I'm also deeply indebted to my mentors, colleagues, and students at MIT, where I have spent virtually my entire life as an economist, and who continually challenge, stimulate, and enrich my work. I'm extremely grateful to my many co-authors from whom I and my research benefit enormously. I particularly wanted to recognize two of my co-authors with whom I have done a great deal of my work. I have worked with Laurent Einev for almost a decade now on various issues related to asymmetric information in health insurance markets, and I have learned and continue to learn an immeasurable amount from him. I have also had the privilege of directing the Oregon health insurance experiment with Kate Baker, and I can't imagine a better partner in this endeavor. I noticed with interest that the next honoree tonight is Joe Newhouse, who was the principal investigator of the RAND health insurance experiment and has been one of our collaborators on the Oregon health insurance experiment. Kate and I have been privileged to benefit from his expertise and sage counsel throughout this project. I hope and I believe that randomized evaluations like the RAND experiment in the 70s and the Oregon health insurance experiment of randomly giving some low-income uninsured individuals Medicaid and others not are poised to move closer to the norm rather than the exception in health economics. The enormous attention that they have received, and in the case of Joe's RAND experiment, its long-lasting influence, speaks to the unique clarity and credibility of randomized evaluations to answer important questions in economics and policy. Over the last decade, randomized evaluations have become increasingly commonplace in development economics and in domestic education research. I recently co-founded a research center at MIT together with Larry Katz to promote and encourage more domestic randomized evaluations. This center, JPEL North America, spans the spectrum of domestic topics, but naturally a particular interest of mine is health economics. And with this in mind, JPEL North America has launched a U.S. healthcare delivery initiative with generous funding from the Laura and John Arnold Foundation to encourage randomized evaluations on interventions to improve the efficiency of U.S. healthcare delivery. I'm sure there are many people in this audience who have a lot to contribute, and there are many partners in the world out there, hospitals, insurers, employers, who we can work with to collectively work on randomized evaluations to improve what we know about how to improve the efficiency of the U.S. healthcare sector. And I hope that this conference and this type of award helps to promote that kind of activity. Thank you very much.
The final award is the Lifetime Achievement Award, which this year is given to Joe Newhouse. Joe is the John D. MacArthur Professor of Health Policy and Management at Harvard University, where he's been since the late 80s. Formerly, he was at the Rand Corporation in Santa Monica, here in Santa Monica. He's an old friend of mine. I actually met him 50 years ago, and he encouraged me. He probably doesn't remember it, to do health economics. We had some conversation, and I can't remember exactly. We were writing somewhere, and we discussed this. Vic Fuchs, who is one of the first scholars to enter the field of health economics, will introduce Joe in a video.
It is a great pleasure and high honor to present the ASHE Award for Lifetime Achievement in Health Economics to Joe Newhouse. Congratulations to Joe, and congratulations to ASHE for recognizing Professor Newhouse's extraordinary contributions to the field. Elizabeth Barrett Browning, poetic tribute to her husband, Robert, begins, "How do I love thee? Let me count the ways." Similarly, we may ask, why do we honor Joe Newhouse? Let me count the ways. First, early in his career, Joe designed and directed the Rand health insurance experiment. This was, in my judgment, the best executed of all the country's controlled social experiments. Some 40 years after publication, the Rand results are still cited. Second, in 1981, Joe founded the Journal of Health Economics and edited it for the next 30 years. He made it the foremost journal in the field and one of the most successful specialized journals in all of economics. Third, in 1988, Joe became the John D. MacArthur Professor of Health Policy and Management at Harvard, where he serves on 4 faculties: Arts and Sciences, the Medical School, the School of Public Health, and the Kennedy School. Over the past quarter century, he has built an outstanding graduate program, securing major grants, recruiting faculty, teaching, and mentoring. He has served on 70 dissertation committees. Fourth, Joe's career refutes the old saying, those who can do, those who can't teach, and those who can't teach, teach teachers to teach. He has taught with great success, including many students who have gone on to their own academic careers. But he certainly can do. In our occupation, a frequent measure of doing is publication. Joe's CV lists 423 papers and other publications. That's right, 423. Some are of exceptionally high quality. 2 won the Kenneth J. Arrow Award for the best article in health economics. Another won the Zvi Grilikis Award for the best empirical article in the Quarterly of Journal of Economics. Finally, despite his enormous commitment to research, teaching, editing, and administration, Joe has found extensive time for public service to government and the academic community. He has helped many major organizations, including the IOM, the AAMC, the COB, and the National Research Council. When an important issue involving healthcare research comes up, Joe is the first one to get called. He has been president of the Association of Health Services Research, the Foundation for Health Services Research, the International Health Economics Association, and he was the first president of ASH. I have focused on Joe's contributions and achievements in the belief that an award ceremony is not the time to go all sentimental. Full disclosure, however, requires me to acknowledge that Joe and I have been good friends for a long time. We first met when Joe was a graduate student. Since then, we have interacted frequently at national and international conferences and at visits to Stanford and Harvard. Our wives became good friends, and if Beverly were alive, she would be joining me in sending best wishes to Joe and Meg. Beverly was from Brooklyn, which had a baseball team, the Dodgers, managed by Leo the Lip DeRocha. Leo was a feisty, combative little guy who defended his style by saying, "Nice guys always finish last." How wrong he was. Joe Newhouse has shown that sometimes nice guys finish first.
Well, thank you very much, and I certainly want to thank Victor for those excessively generous remarks. It's very meaningful to me to have the Victor Fuchs Award presented by Victor Fuchs, and there's nothing more honoring than being honored by your peers. Like Amy, I want to thank my mentors, especially John Dunlop, who trained both Frank Sloan and myself, and my former colleagues at RAND, from whom I learned a lot, and my current colleagues at Harvard. And I'd also like to thank my family to get to what I've done. It was really important to have a supportive wife. My wife Meg supported me all the way. And my children taught me some lessons. They would roll their eyes when I would make remarks like life is a giant constrained maximization. You never know what influence you have. When my younger son applied to graduate school in economics, he said, would I read his essay on why he wanted to apply? So I did, and it started out when I was 7, I remember after dinner, Dad would go into the living room and read economics journals, and I decided economics must be both interesting and important, so, which I agree with. So again, thank you very much, and particularly the awards committee, I'm very appreciative of the award.
We are going to move to the second part of the program, and it is my honor to introduce Leonard Schaeffer, who will be with the panel here. Leonard Schaeffer has an impressive career, and I could spend the rest of the time here reviewing his achievements and various prestigious positions that he has held in government, the private sector, and in academia. But what is likely the most important to mention in this forum is that Leonard Schaeffer is probably the single greatest philanthropist to the field of health economics. In fact, nearly everyone in this room has likely in some way benefited from his generosity and his vision. It is for this reason that we're honored that he could be here with us tonight and introduce the panel on payment reform, which will include Leonard Schaeffer Chairs from around the U.S. So let's welcome Leonard Schaeffer.
Well, thank you very much, Frank, and thank all of you for being here tonight. It's my pleasure to introduce the panel on innovative models in payment reform. But before I do that, I'd like to thank Dana Goldman and all the people on his staff who worked so hard to make this meeting such a great success. I think they have done a terrific job, so please join me. Now, many of you are probably wondering why a non-economist was asked to introduce a panel here. Actually, given that my name is plastered on every surface, you're probably not wondering why I was asked, but you might be wondering how I came to be asked. So let me explain a bit. I came to California in 1986 to run Blue Cross of California. And the first thing I learned about California is that the most innovative approaches in both financing and delivery that I had ever seen were happening right here on the West Coast. So after a few months, I wanted to support more formal research on these topics. But the second thing I learned about California was that Blue Cross of California was insolvent. Not a good word, and led to our inability to fund research or do much of anything for a little while. It took us 3 years to go from the worst performing Blue plan in America, which is saying a lot, to the best performing one. And when we recovered and when we had the financing, we endowed a chair, Blue Cross of California endowed a chair in health policy at Berkeley, which is now occupied by Steve Shortell, and a chair, oddly enough, here at USC that's now occupied by Glenn Melnick. Subsequently, it became even more clear to me that in terms of healthcare financing and delivery, geography is destiny. The historic accidents of where people live, where medical schools, hospitals, and doctors are located, and how healthcare is funded and regulated shape the way care is delivered and consumed. So I thought it was important to support researchers in different geographic locations who can observe and experience these differences and make recommendations about what we ought to do in the future. However, as a single state company, Blue Cross of California was not in a position to support research all over the country. But we wanted to expand, so we needed what was called acquisition capital. If you want to buy something, you got to have, well, you guys know that. You have to have resources to acquire it. So we created a for-profit subsidiary that was called WellPoint. Eventually, WellPoint went public, and it bought its parent and 16 other companies, and in the process established 5 foundations with assets of over $6 billion, some of which support research by health economists. However, the final lesson I learned here in California is that a small percentage of a very large number is still a very large number. I'm sure you all understand that. So when I retired from WellPoint, it had a market capitalization of $50 billion. And that meant I had enough stock to establish 5 chairs in healthcare policy and economics at 5 different institutions. 4 of the folks that occupy those chairs are with us tonight, and I'd like to introduce them now. Dana Goldman is our panel moderator, and Dana has the Schaeffer Director's Chair in Health Policy at USC. He's also director of the Schaeffer Center for Health Policy and Economics. He advises the CBO, Covered California, which is our health exchange here in California, and the Fred Hutchinson Cancer Institute. He's a member of the Institute of Medicine, and he has received numerous awards: the MetLife Foundation Silver Scholar Award, the Eugene Garfield Economic Impact Prize, and a bunch of other stuff. Before I introduce the rest of the panel, I want to refer you to their full bios and publications that are in your program, because I can't do them justice. Our first speaker, who is going to talk about ACOs, is Alice Rivlin. She's director of the Engelberg Center for Healthcare Reform at Brookings. She holds the Schaeffer Chair in Health Policy Studies there and is a senior fellow in economic studies. She's also a visiting professor at the Public Policy Institute at Georgetown. In 2010, President Obama appointed her to the Simpson-Bowles Commission. She also co-chaired with former Senator Pete Domenici the Bipartisan Policy Center's Debt Reduction Task Force. Alice has had a spectacular career. She was director of the OMB from 94 to 96 and served as vice chair of the Federal Reserve Board from 96 to 99. She founded the independent and nonpartisan CBO in 1975 and served until 1983, and she's received the MacArthur Foundation Prize Fellowship. So I am very proud and very pleased that she occupies one of the Schaeffer Chairs. Mike Chernew will speak next. He'll describe his views on provider-directed payment reforms. He's the Schaeffer Professor of Healthcare Policy at Harvard Medical School. He's a member of CBO's panel of health advisors, and he's a member of the Institute of Medicine. He serves on the IOM Committee on National Statistics and previously served on the IOM Committee on the Determination of Essential Health Benefits, a committee I also served on, and I thought we did outstanding work. That was a joke. Okay? He's also served on technical advisory panels for CMS that reviews its assumptions used in the used by Medicare actuaries. He's also a research associate in the National Bureau of Economic Research. Finally, Jamie Robinson will offer his comments on consumer-directed payment reforms. He's the Schaeffer Professor of Health Economics and Director at the Berkeley Center on Health Technology at UC Berkeley. His research and teaching focuses on biotechnology, medical devices, insurance, and healthcare delivery sectors. He's also a director of the Integrated Healthcare Association and a contributing editor for the Health Affairs Journal. His most recent book, Value-Based Purchasing of Medical Technology, will be available soon. On behalf of Jamie, I urge you all to go out and buy it. I want to thank all of our panelists for taking the time to join us, and if they come out, they will begin talking, and I will leave you all in peace. Thank you very much.
Thank you, Leonard, for that kind introduction. Our conference theme is economics to policy, and that reflects the Schaeffer Center's vision that we can use economic analysis to improve healthcare delivery, and I think these plenary sessions perfectly encapsulate that view. It's also a vision that's shared by Leonard and his family, and I do want to take this opportunity to thank him publicly for his exceptional generosity in supporting health economics. I think it's fair to say, as Frank said, that among philanthropists, he's done more to advance health economics and health policy than any other American. So thank you very much. I also want to thank Quintiles for their generous support of this session and the Schaeffer Center. They've demonstrated a commitment to finding innovative solutions in healthcare, and I can think of no more pressing issue than payment reform. So let's get started, I want to note there were two news stories yesterday that caught my eye. First, Andrew Pollack wrote in the New York Times about the latest efforts by PBMs like Express Scripts and CVS to control costs. He pointed out that there's a new imperative in the pharmaceutical marketplace, basically can be summarized as bargain or be banned. Meanwhile, the LA Times reported in California that officials are investigating two large insurers for creating, quote, overly narrow, unquote, networks. So the question, of course, is whether these are attempts to generate more value, or is this really just a euphemism for cost containment in any guise, and is such ruthless price competition necessary to sustain our healthcare system? And at the center of this maelstrom is the movement towards accountable care organizations. So let me start with Alice Rivlin and ask, are ACOs the latest fad, or will they change how healthcare is delivered?
Well, Dana, I think that's the big question, and it's the one I would like to address. But first, let me say I'm very proud to be the Schaeffer Chair at the Brookings Institution, and very grateful to Leonard Schaeffer for all he has done for improving research in healthcare. I don't think we'd have much argument in this room that we need an alternative to fee-for-service that will evolve over time to do two things: to produce higher quality care at a sustainable cost. And I think sustainable cost, sustainable total spending, doesn't grow much faster than our economy can grow. and that will be broadly acceptable to patients and providers and payers, including taxpayers. There's a consensus on that much, but the question, as Dana said, is are accountable care organizations, the current vogue, are they a viable framework for being that alternative or not? ACOs are loosely defined as groups of providers that agree to accept responsibility for a group of patients and share in the savings if they can meet quality standards and reduce spending below a benchmark baseline, and eventually share in the losses if they don't perform. So far, ACOs are a pretty soft concept, pretty loosey-goosey. Definitely a work in progress. The major federal government demonstrations are two, the group of pioneers and the shared saving model. And there are multiple examples of private payers also trying out this idea in different ways. There are about 250 private ACOs at the moment. Now, most ACOs are physician-led, although some include hospitals, and a few include other providers, and a few are actually led by hospitals. I think the physician leadership is a very good aspect because patients tend to trust their docs. We need buy-in from the doctors if something's really going to work going forward. And the most obvious savings from care coordination are keeping patients out of hospitals and especially out of emergency rooms. And hospital-led ACOs aren't really likely to be terribly good at that. So far, we have very few results. We have 1 year of pioneer and shared savings results. They are realistically described as mixed, and optimistically described as promising, but most ACOs have met the quality standards. Some have had enough savings to get modest rewards. Not much is known about the private sector, which is often true, but the expansion of the model would lead us to believe that at least many payers think this is a good idea. So, are we looking at the first hesitant steps of a model that will grow more robust over time, or one that will fizzle? We don't know. First, the ACO model has to be better defined. We have to get rid of the uncertainty about which patients the ACO is responsible for. At the moment, in the federal programs, patients are attributed to an ACO if they get half their care from it. But inevitably, they get a lot of care elsewhere, and it's hard for an ACO to take active responsibility if they don't control the bulk of the patient's care. Worse than that, I think, patients don't know they're in an ACO. Or they may not. The ACOs need to engage patients in their care if they are to succeed. That leads me to believe that we need an enrollment model with the patient getting something for being in an ACO, possibly a discount on their Part B premium if it's a Medicare ACO, or a lower copay if they use the ACO network. Another problem is that measures of quality and outcome have to be improved. Mostly they're process measures at the moment, and they have to move toward acceptable measures of population health. That's hard work, and it's going to have to keep evolving with experience. And ACOs need more skin in the game. So far, most ACOs tend to get modest rewards if they perform well, but they can't lose. Serious transformations of practice will take more serious incentives, both rewards and penalties. That suggests two-sided risk. Docs are very risk-averse. We are all very risk-averse. but some of this risk problem can be mitigated by reinsurance and by experience with improving risk adjustment. Now, this sounds like ACOs might take over the insurance function, might eliminate a whole layer, namely insurance companies, who aren't that popular anyway, and put providers in the position of managing risk. One can imagine a future in which almost everyone is in a capitated plan that provides services and manages risk, and patients choose which one they want to be in on the basis of good information on costs and outcomes. Whoa, we're a long way from there. A big question is how hard and how fast to push this experiment. Peter Orszag, in his opening remarks on Tuesday night, urged Sylvia Burwell, our new HHS secretary, to lay out a firm timeline and say where the system should move when and what the end game was. I'm not so sure. The risk of any Obama administration executive taking a position is that it gets immediately demonized. We don't want a backlash like the HMO backlash back a few years ago. So I would urge proceeding with caution, but proceeding. And besides, there are other approaches to payment reform, and my colleagues are going to expand on those.
Thank you, Alice. One of the things Peter said in his remarks was that he thought 75% of the Medicare payments should be at risk, and you mentioned more skin in the game. Mike, where should we be moving in terms of physician payment?
Well, I think my understanding is last night there was a lot of fireworks around the discussion. I'm not sure there's going to be a lot here. I'm going to agree with Alice. I'm going to thank Leonard, and I really am honored to be a
That's
Schaeffer.
the most controversial remark.
No, well, in some audiences. I'm honored to be a Schaeffer Chair, and his contributions to the field are really immense. And so I couldn't be happier to be associated with this group of folks. I'm also agree with her in terms of her discussion about ACOs and payment reforms. In fact, I think the term ACO focuses on the organization, but if you listen to Alice's remarks, a lot of it underlying relates to the payment. And I think we're pushing in a world that's trying to move to broad accountability, and doing that by moving away from fee-for-service towards a whole range of systems that hold the provider system accountable. I will assert that maybe in answer to Alice's questions, the fundamental motivation of a lot of this is basically cost containment. I think if you look at the federal budget picture, if you look at what's going on in the private sector, organizations feel that there has to be some group to take responsibility, and they want to put that responsibility on providers, and that's happening through ACOs and a whole series of payment mechanisms. What I like about this movement in terms of payment is it allows the provider system to capture the efficiencies that they generate. Under a fee-for-service world, if providers capture efficiencies, they then flow back to the insurance sector, whereas in a bundled payment world, those efficiencies can be captured by the organizations. In many models, of course, people then want the payer to take back those efficiencies very rapidly. My personal view is you should allow those efficiencies to be captured by the providers, otherwise they won't materialize. And the way to win in this system, at least fiscally win, is to control the rate of the payment over time, the bundled payment, the target, whatever it happens to be. I'll return to that a little bit later. There's a lot of concern about how providers are going to respond. My general view is when money gets tight, and money's going to get tight, providers want to control the money, and the whole theme of all of this payment reform is a mechanism to allow the providers to control the money. My sense is that fee-for-service, at least the way we're going to practice it in the future, is going to be a road to insanity with lower rates, more volume pressure, more regulation to prevent the volume pressure, and it's not going to be enjoyable for anyone. And so payment reform broadly, ACOs being one manifestation, or the idea of how to get around that. And of course, Alice pointed out, and I think correctly, the theory sounds great. It's can we make the details work given all of the constraints? So can providers succeed? Do they have the data? What if they integrate? What if the providers all become one large medical group? How do you manage that system? particularly outside of the Medicare system where you don't have control on prices. And what you're going to see is multiple models. So there's the ACO model, which Alice spoke of, which is largely a global budget with relatively little downside risk, and a bunch of other regulations. In the private sector, you're going to see a lot more two-sided risk. We used to call that capitation, but that's not a polite word anymore, so I hope we're not being videotaped. And there probably are some differences. The other type of payment reform that you see besides that is bundled payments, where you pick a particular service, a hip, a knee, some other service like that, and pay, in Arkansas, they call it a principal accountable provider who's responsible for care over a period of time. I think it's a reasonable model, but it's very hard to figure out how to make that work when people have multiple situations. You have diabetics that could be getting a bundled payment for diabetes who need a hip replacement. You have to do a lot of accounting to parse that out. On the other hand, the bundled payment models meet the delivery system where the delivery system is. To move to an ACO, to move to accept any of these other more global models, you need an organization underneath it that's different than we have in a lot of different parts of the country. The big question for all of these, because as I said, I think the main motivation is cost containment, is how we're going to set the rate. So one of the ways, of course, is competition. I worry about provider-side consolidation if we're going to set the rates competitively. You could try yardstick competition, looking at other markets and then setting the rates, and that again could work, but it depends on how competitive those other markets are. One of the reasons I think we're here as a country is we're afraid of administrative prices. We're afraid of setting prices, and I think we're going to have to think about how to do that. My view from MedPAC in general is it's really hard, and by that I mean impossible, to get the prices right, although you don't have a perfect system otherwise. On the other hand, you might encourage systems that have some flexibility, a percentage of Medicare, for example, or some other way to try and control prices. In the end of the day, I think we're going to set these rates based on what we can afford, at least for the public payers. And I think that's what's going to matter. We have to work through how we're going to share and regulate the risk, how we're going to do the risk adjustment, how we're going to measure quality, Alice mentioned. Jamie's going to talk about how we integrate with benefit design, so I won't go there, but I do think that's going to be an important issue. I will say that I read the evidence slightly more optimistic than Alice, not about the Medicare ACOs, which I think have a range of issues. I think if you look at the provider sector and actually longer research on capitation, providers change their behavior when you change their financial incentives. The work that we did in Massachusetts, the providers were really good shoppers when they were shopping for themselves. They managed utilization in ways that they hadn't managed before. I don't believe that every market and every delivery system configuration will be as successful. I believe there's tools that are going to need to be put in place and a range of other changes. So I'm not quite ready to jump for joy, nip up, as Catherine used to say. But I do think there's some optimism there. So we will have to see, but one way or another, we are going to control the spending trajectory we have in the United States, and it strikes me that payment reform is a reasonable way to do that because it allows it incents and allows the provider system to move and win if the system evolves the way that I think we'd like and need it to evolve.
Thank you. That was great. And most of the ACA, when it comes to cost containment, is focused on providers and payment reform. Jamie, what else can we do on the patient side?
Cost sharing comes in and out of favor in among health economists and health policy people. Obviously, immense research on the topic. I went to some great papers on the topic today, and we know two things. First of all, cost sharing works. People are more cautious about spending their own money than spending other people's money, such as the insurance company's money. And secondly, that when people face cost sharing, they use less services, but they're sort of indiscriminate reductions, and cost sharing contributes to lack of engagement and adherence to effective therapies, as well as reducing perhaps unnecessary care. Put those two together, and many of the right-thinking people in the economics and the policy world favor putting the incentive on the providers, as we've heard about before. And I am a long-term sympathizer of prepaid group practice and its followers being here in the California market. And the dilemma there, if you're a long-term believer in that, which I have been, and many of us are, is that if ACOs or prepaid group practices and capitation are so efficient, how come they haven't swept the entire market? What's wrong there? And that leads me to the first of my Leonard Schaeffer stories. Okay. Well, before I went to graduate school, I was a newspaper reporter, and I never totally lost my journalistic, like to go out to talk to people about what is really going on. So back a couple decades ago, I was doing a lot of this because everybody, all right-minded people, believed back then that capitation and organized medical group was going to sweep the market, and it was just going to be all that old-fashioned fee-for-service PPO stuff was just completely going to be wiped out. And the only person who didn't believe that, apparently, was Leonard Schaeffer. And I thought that was interesting. So I started spending a lot of time trying to understand what Blue Cross was doing, and did a lot of meetings with a lot of Blue Cross executives. But I know people who know people, and so I just kind of get in, make appointments, and talk to people. The word percolated up that there was some professor asking a whole lot of picky questions about business practices at Blue Cross. And so when I finally got a meeting with Leonard, he had, of course, very generous with his time and everything. And afterwards, he issued what I believe was a fatwa saying that no executive at Blue Cross of California shall talk to Professor Robinson without someone from corporate public relations being there. And so after that, I had great access, but always
here at USC.
Yeah. So, but anyway, I did spend a lot of time at Blue Cross and learned a lot about the importance of provider organization and payment, but also of the role of the consumer. And I think the main reason why we haven't seen a greater sweep of the nation for more efficient forms of provider organization and payment is that there has not been the conventional business reward, which is if you develop a more efficient product, you get more customers. And there hasn't been a consumer cost-sharing movement at that time. In fact, the long-term trend has been less and less cost-sharing over time, with a little bit of a turnaround very recently. And you know, I guess we can all say cost-sharing is back. I don't know what's going on in Washington. I know what's going on the market, and it's called cost-sharing. We've all seen the Kaiser HRET surveys of about 43% of employers now offering high deductible plans. I personally am more impressed by the health insurance exchanges here in the great state of California. We have 1.3 million people who have enrolled in health plans through Covered California, our health insurance exchange. 90% of them are in high deductible health plans. The reason is that the marginal premium dollar is their own dollar, and so they're going for it, both the subsidized and the non-subsidized. Non-subsidized are all bronze. It's really quite striking. Bronze is pretty thin benefit design, and narrow network, those put together. So I think that cost sharing is growing. It's here to stay. It's not going away. So the question is to those of us in the research and in the policy advisory and management advisory world is to say, well, how can we maximize its good effects and minimize its bad effects? That's really, and then how can it provide an incentive for consumers to join more efficient provider organizations? That's really what you want them to do. And I'm just going to make a very brief comment about reference pricing. Reference pricing, which is a terrible term, it's actually a form of defined contribution. By the way, the solution of consumer cost sharing is defined contribution. The concept of defined contribution, we're all familiar with it from managed competition. The sponsor, the employer, whoever makes a fixed contribution towards your choice of health plan, and you pay the marginal premium yourself. That gives you an incentive to compare premiums. That's University of California does that. Probably USC does that for their health benefits. And that works well, but what we see out there in the market is unbelievable variation, not only in health plan prices, but in the prices of services, physician services, particularly ancillaries, lab tests, imaging tests, ambulatory surgery, et cetera. And the reason is not surprising. It's that consumers have not paid the marginal dollar out of their own pocket. It's they went through whatever copay, whatever deductible they have to go through, and then at that point the insurance company is paying, and then why do we care? So reference pricing is really taking defined contribution down to the level of the procedure or the episode, and I work a lot with employers that are interested in that. It's a common thing. So I work with PERS and Safeway and other entities, and just think like a Safeway. Safeway, big grocer, retailer, they were paying, within the same market in Houston and here and Portland, between $700 and $7,000 for a diagnostic colonoscopy, just to take one example. There's no quality differences there worth talking about, right? So they said, why are we paying so much? We're about to go bankrupt. We're competing with something called Walmart. We have got to do something. So they set a contribution limit of $1,250. If you're the employee, they'll pay up to $1,250. You pay 100% of the remainder, not 20%, and no out-of-pocket max. It's a non-covered benefit. You pay all of it. Same thing, PERS for orthopedic surgery. They were paying $20,000 to $120,000 for a routine hip and knee replacement non-emergency. You know, this was about 5 years ago. State of California 5 years ago was essentially bankrupt. If you remember, there was the Great Recession was going on. So it was either, you know, raise tuition even higher at the University of California or do reference pricing, and they made the right choice. And anyway, the experience shows is that when people are, this is a way of giving incentives for people to choose on the basis of price, the marginal price, not the average price. And then, of course, we need transparency, we need quality data, we need to restrict this to services which are what we call shoppable, non-emergency stuff, not at the frontiers of science, you know. But I do believe it's a common thing. It's just one example of what the market is doing out there to try to make the consumers aware of the marginal price of what they do, which will then give an incentive to the provider to compete on the basis of price. And what we found, of course, in orthosurgery was that when faced with the prospect of losing their PPO patients, hospitals changed. Because hospitals lose money on Medicaid. If they're good, they break even on Medicare if they're good. HMO in this state is about at Medicare rates, and so PPO, they're making all their money on PPO. So you lose your PPO patients, you're dead. And so they really did price compete. So anyway, it's just an example of consumer cost sharing, and all of us, we're going to be studying it, and hopefully, as Alice said, there will be a market reward for those physicians and hospitals that do form efficient ACOs, whatever we call them, and the greatest market reward should be more patients.
Thank you. I want to talk a little bit about risk. So a lot of health economics is really about who bears risk and who manages it. And in the 1950s, AT&T was the largest private employer. It had a very generous benefit, and people stayed very long tenured jobs, and they could count on a pension there. Now Walmart is actually the largest private employer. You mentioned that they have a defined contribution plan. We've seen this movement in pensions. Essentially what has happened over the last few decades is we've moved, because of concerns of cost containment, we're starting to move, transferring risk from insurers and government to individuals, and now you're talking with ACOs about transferring risk to doctors. And historically, we don't want doctors to manage money. That's been my feeling. But so the question I have for the group is, are we transferring too much risk because of cost containment to individuals and providers, and what would be the consequences? And I'll open it up to any of you to discuss it.
Well, I think we could. It depends how we do it. You can certainly cost sharing that involves very low income people paying a lot is certainly going to be doing that and to have quite negative effects on the care they get. But in a way, I think we make too much of the risk. I mean, take transferring risk to an ACO that has a significant body of patients and is presumably in, let's say it's in primary care. There ought to be a way that their payer, say it's Medicare, can do reasonable risk adjustment on the payments. Now, people say, well, it's very hard to do, and we don't have enough experience, but experience accumulates pretty rapidly. And then there's also the question of reinsurance. There's no reason why an entity that is bearing risk can't insure itself.
And isn't that how we ended up with Medigap, though? And Mike, did you want to comment?
No, keep going, Medigap.
Please.
I'm not going to interrupt the host. I'm going to get kicked off.
No, go ahead, please.
My sense is that there are going to be limits to how much risk we can transfer to consumers, and they're going to be in particular areas. I think it's very different if you just charge them high co-pays and manage the sort of stochastic part of the risk that way, as opposed to reference pricing, where they can get around the risk by changing their behavior. And we need a lot more work to understand how flexible they are, how much risk is really being transferred, whether you're giving them acceptable ways away from that risk. In terms of the provider side, and I know definitive always sells better, so I'll go with no. I would draw the distinction between what I would call stochastic risk, which is what really we talk about risk, and we solve that basically with sample size, and then there's managerial risk. If you don't manage your patients very well, you lose money. And I basically don't have a problem with giving the responsibility to manage patients more efficiently to providers and with upside and downside risk, basically because the alternative is spending money that I think we don't have and can't afford. And so if they're in this whole, Jamie already mentioned consumers don't make great choices, the evidence suggests, and I'm mildly skeptical of the ability of the government to do it in any sort of broad micro way. So although I'm not sure that providers are thrilled about it, one way or another through the provider system, I think they're going to have to be the ones that step up and try and deal with the management side of risk.
Thank you. I want to also, in your remarks, both Alice and Mike, you touched on the issue of collusion. I don't think you used that term, but the idea is providers getting together and forming ACOs, for example, large ACOs. And we do that for accountability, but we also worry about competition. And I want to ask you, and you may not know the answer, clearly, historically, there's been some economies of scale that have justified getting together, but for those of you who spend time in Los Angeles, you know, on the west side of LA, for example, UCLA owns everything. And if you're an insurer, it's almost impossible to exclude them from the network. And so do you believe that, one, narrow networks are going to be successful in containing costs, and two, is provider collusion or provider consolidation something that would actually give you some discouragement about that? Jamie, did you want to?
Okay, I'll have a couple comments on that. I think that narrow networks, when done well, can be very efficient, very impressive. I mean, Kaiser Permanente is a narrow network. Geisinger Health Plan is a narrow network. If they grow up together, they can be very efficient. A lot of the networks that we're coming together right now are going to fall short of that ideal, but they are going to be cheaper, and they are going to be there. I think they're going to be there. In terms of the collusion, not collusion, just market.
Consolidation. We've decided to change the word.
Much of the attention, of course, has been on the hospital side and hospital pricing. I just have done a study with the IHA. We're going to get that. It's coming out soon. On in the California capitated context, hospital acquisitions of medical groups and the effect of that. And they are focused on total cost of care, not prices, but total cost, physician cost, ambulatory, hospital, pharmacy, everything, all in. On a risk-adjusted basis, and the reality is that these consolidated systems are higher cost. And I think the mechanisms are not, it's not like, oh, an antitrust, or we're going to leverage a higher price per se. I mean, that can be an element of it, but it's rather that these large systems, the medical groups, they then admit to the hospital that purchased them. That hospital often is a high-cost hospital. They take their ambulatory surgery out of the freestanding centers, they move it into the hospital-based centers. There's just a whole variety when that goes for diagnostic imaging, et cetera. And so the hospital systems are very cautious about moving strongly further down the path of utilization management because their censuses are dropping, et cetera. So I do believe it's a concern. I don't think it's a classic hospital price leverage per se. I think that there's an element to it, but it's really the cost of care and utilization practices in large systems. And large systems are not necessarily the most efficient systems.
Mike, did you, or Alice? Why don't we do Mike then, Alice?
No. So the quick answer is yes, that's a big concern. I think there's going to be markets. The providers in the 90s, I think, pushed back. I think the natural thing for providers now is to push back and consolidate. And I think we're going to, I don't know if Lee Moore is here, I saw her earlier, or Marty. I'm sure there's a lot of others. We're going to have to give some serious thought is how we're going to manage competition on the provider side if any of these consumer or payment mechanisms are going to be successful.
And by the way, CalPERS, we have excluded UCLA from the network.
But USC,
it can be done.
USC's in?
I think Harbor USC is in, yeah.
Okay, because otherwise you'd have to leave.
Alice, please.
I agree with all of that. I think it's a major concern. But this is a very big, diverse country. And I've been reminded of that when we were talking with Senator Max Baucus from Montana, who is chairman of the Senate Finance Committee, in lots of conversations about the exchanges. And his comment was, or his question was always, well, what about Montana? And Montana's very different. It's not LA. It's very sparsely populated. There aren't very many providers, and you have a whole different situation.
Mm-hmm. Yeah. And the next meeting is in Montana?
They have more senators than they have providers.
We're here tonight, and there are a lot of young researchers, students in the audience, and I'm wondering, we are trying to move from economics to policy. When you think about payment reform, what are the unanswered questions that you would like to know that could help guide their research as they build their careers? Did anyone want to take that?
I mean, I'll say, since I did payment reform, there's the beauty of the time period we live in is there's a vast number of different models. And so there's an enormous amount of work to be done to understand which models are working. I don't think there's going to simply be one answer, incidentally. It's going to be contextual. So there's a lot of issues about that. Understand why they're working. Are they working in different populations? What are the cost implications? What are the quality implications? There's a lot to be done on the associated tools to make the system work. How do you measure quality, Alice mentioned. How do you do risk adjustment better, I think is important. How providers feel about it, how patients feel about it. There's going to be such diversity of where we move ahead that there's going to be an enormous amount of opportunity, I think, for academics to look at it and look at it in a rigorous way. One thing that I worry about is a lot of the evaluations you see generally are uncontrolled. They look at just trends. They look at small, one outcome measures as opposed to overall things. And so I think there's a lot of room for good economics to evaluate what I think is going to be a vast number of interactions. Spillover effects, for example, I think will be important.
I want to put in a plea for serious work on quality and outcome measures. It's a really hard problem, and as I see it, it's not very far advanced. And the problem is very similar to the one in education, the teaching to the test problem, and if you get too specific set of measures, then everybody's going to do that and not neglect all these other things. And not to mention the VA example of if you measure how quickly patients get approved, there's an enormous chance of cheating. But these are very interesting problems, especially in healthcare, and I would think it would be a very good contribution to work on them.
And the advice I would give the researcher is to develop yourself a little competitive advantage in your research domain. In other words, don't study what everybody else has already studied. There's a lot of interesting experiments, payment methods, benefit design issues going on out there. But to study them, you can't use the usual databases and the usual approaches. And so a lot of people do that, but I like to encourage people to use proprietary databases. This does require efforts like by the centers, like the Schaeffer Chairs, working with certain employers or whatever. I work a lot with Anthem or WellPoint, their data. It's really useful to have actual data. There's other people that work with United data. and also to do a certain amount of qualitative work just to really understand what it is you're really looking at. Because data are often really, it's very easy to misinterpret data. You really go out and need something to talk to people. Just give an example. Those of us that work in the cancer domain fret a lot about the perverse incentives facing oncologists with respect to prescribing oncology drugs and all that stuff. It's clear that the best provider payment method would be some sort of blend of maybe fee-for-service for the office visit, that's probably okay, some sort of at-cost reimbursement for the drug, so it's not a big markup thing, and then some sort of care management, case management thing that would give them the incentive to really proactively be in touch, monitoring the patients, keep them in, all that kind of stuff. Well, it's very hard to do that. Medicare doesn't do that. I mean, it's very hard to do that. But in fact, you know, WellPoint's just rolled this thing out, a version of this nationally. To study that, you've got to talk to them. What's going on? What's really going on? Talk to the people that are doing it. And also, if you have access to their data, to actually look at that. If you're in the cancer world, that's big. That's not, you know, if you're not in the cancer world, forget it. But it's an example of a great researchable topic, or whether it's, you know, the Massachusetts Blues, their payment methods, or whether it's just sort of localized. Get in there, get to know them well enough, study it, and then the world actually does want to hear about it, because I believe that the greatest problem facing reform of the healthcare system is not a lack of cool, interesting things happening all over the place. It's rather, we have a very difficult time diffusing. Some great thing happens, and then it stays over there, and it doesn't diffuse. And the researchers can play a role in that, which is helping to illuminate and explain it. But then you have to really understand it.
Thank you. Okay, I do want to invite audience questions. You can come up to the microphone, and while we're doing that, please, while you're trying to get up your courage, let me ask another question of the panel, which is, we haven't talked a lot about changing the provider mix, and we know that certain other providers other than physicians can provide care. I'm in a pharmacy school, for example, and I've learned how effectively clinical pharmacists can deliver chronic care management. What can be done, and Mike, I'll direct this question to you because you talked about bundled payment. Are the incentives appropriate, and what about the regulatory system to allow alternative models of care delivery?
So I think we're at the foot of the mountain. In doing that, I think is one of the motivations for these payment changes is to allow delivery systems to capture the savings when they do things, not just in terms of workforce, but other things like e-visits, how you're going to do chronic care management. So I think we're getting the regulatory issues right. I think there's a lot to be done actually on aspects of education, both for physicians and others. And there are a lot of regulatory issues, nursing regulations around nurse staffing, for example, that I think are going to be important. So we had a system that was designed in many ways to prevent use of certain types of services, limiting new codes and things. And we're moving to a system where we want a lot more flexibility. And so I think it will be a wonderful research topic, and I think there will be a lot of systems that will be exploring how to change the production function of healthcare.
Great.
Hi, Vivian Ho, Rice University. Thanks for a very informative panel. You covered a lot of ground. I wanted to ask you about the role of health economists in their relationship to CMS. They're playing such an important part in terms of all this provider reimbursement, what you've talked about in terms of ACOs and bundled payments and all this. You look at this conference, we have health economists from NIH here, we have health economists from AHRQ. I don't know any health economists at CMS, and is that what we want when you know they're given the instructions to implement the legislation, how to design these reimbursement rates, and you know, Mike, you serve on MedPAC, and is that sufficient, or should we push for more health economists there? I
wanted to defer to Alice, but I think the bottom line is there are, I think, reasonably, in fact, very good people at CMS, and I think folks have a lot of interaction. I've had a lot of interaction with folks there about aspects of their payment model. The one thing I will say is, hopefully in some other auditorium nearby, there's a political science conference going on, because the politics around some of the things that Alice was talking about and what you actually can do are important. So in order to move things forward, you need not only have a good sense of the economics, you need to have a good sense of the policy and the politics. And don't underestimate the importance of politics in mechanism design and where we're going to go. So I'm not worried a ton about actually the CMS per se. I think they reach out. There's a lot of discussions going on with them. I am worried about the relationship between the politics and the general communication to the public and how that interfaces with economics.
Great. Do we have any other questions? Well, people are coming up. I have plenty of questions. Jamie, I want to start with you, which is I'm going to allow everyone to play king for a day. You get one reform, and if you could change one thing in Washington, so it's federal policy, and I want to have a policy change, either in the ACA or Medicare, that would make the system perform better and improve value in healthcare delivery.
Okay, well, I'm sort of on the consumer incentive side of the panel today, and so I'll do a consumer one. For Medicare, I would say I'm with Alice. If the beneficiary chooses a delivery system that has a lower total cost of care, the savings should be shared with the beneficiary through lower Part B premium or whatever the mechanism is. And IHA, we put together a big episode payment thing here, and it floundered. And the reason was that the hospitals and the doctors that put together these programs did not get more patients because the patients weren't paying out of their own pocket. And so shared savings should not be between Medicare and doctors. It should be Medicare, doctors, and beneficiaries.
Mike?
So I agree with that one. Now I have to jump to
Do you just want to say ditto, or?
No, I don't, because I never say ditto. I would, in fixing things like the sustainable growth, I think the most important policy reform broadly going forward is to maintain the pressure on fee-for-service. So that involves things like equalizing payments between settings, being careful when you've patched the SGR to not put it on a trajectory that allows mechanisms for fees to rise very generously, and the pressure on Congress to enable the fee-for-service system to become much more generous is really enormous. And I think the one thing that I would think through as you make these changes is to stick tough on the update rates.
I agree with all of that. I think we could enact all these things and we'd be home free. I mentioned some things I would do to strengthen the ACO model already, so I won't stick with that. But on the theme of putting pressure on fee-for-service, I think the place to do that is Medicare. And I would like to come back to the very controversial proposal for defined contribution in Medicare, sometimes unfortunately known as premium support. Right. Although my friend Paul Ryan probably killed the notion of premium support by putting forth first a very stingy version of it, and then coming to the middle with a more reasonable approach. I do think that if we could define the government's contribution to Medicare, and then allow competition between capitated plans, and you already have that in Medicare Advantage, though not as well structured as it might be, but competition between capitated plans and fee-for-service Medicare over time would make a huge difference.
Now I want to say ditto. But I think we know that Medicare, it took 40 years, but it finally covered prescription drugs. Private sector, as Jamie said, is already doing premium support or defined contributions. So 40 years from now, Alice, you will be right.
Don't want to wait that long.
Yes, we have a question.
Stephen Montemayor, University of Alabama at Birmingham. I'm struck by the absence of the words competitive bidding that have come up so far. And on the issue of what is politically permitted, there have been some attempts to do competitive bidding here and there on different things, durable medical equipment on and off, laboratory outpatient tests, always verboten for Medicare. Some of it allowed in setting premiums and various kinds of bidding for different little aspects of Medicare in terms of Part D plans and what have you. What is biddable in this system? Who would run the auction? Is it really a mode of discovering the low price, or is this something that we're simply not going to see happen?
So the question is competitive bidding and its usefulness. Mike?
Well, Alice's answer was actually a reference in some ways to competitive bidding, at least one version of it. And I would be supportive of some version of that. I think the question, in fact, for economists generally, is how competitive is competitive bidding? And in certain things, durable medical equipment, I think it would work well. I think most of the broad policy discussion of competitive bidding is much bigger, closer to what Alice was talking about. And we could debate the political feasibility of how that goes, but I do think, apart from that, I believe there's still significant outstanding questions about the extent to which across the country a system of competitive bidding would result in an improvement in consumer welfare versus putting the risk of paying for higher systems onto individuals. I don't think we yet fully understand the extent to which competition will or won't work, broadly speaking, in healthcare markets.
And you can also use reference pricing here. It's the same
Yeah,
effect, and you preserve choice.
But I don't think I don't think it's an either or, Mike.
No.
And I share the questioner's outrage about durable medical equipment. I mean, what excuse do you have for not doing competitive bidding on wheelchairs? I mean, that's a no-brainer. And yet, our political system for a long time said Medicare can't allow that. And I think that's outrageous. But we've crossed that.
So Alice, you know, some people might prefer different wheelchairs. Don't you think a reference pricing approach that allows people to choose whatever they want, but sets the government's contribution?
Sure, that's fine.
Okay.
But
you could do both.
That's not where we were.
That's right. No, fair enough.
I think that when you're talking about competitive bidding, we should just never forget about how much the dysfunctions of our system are due to special interests protecting themselves against. And it goes both in Medicare, but it also happens inadvertently in the private sector. And I'll give you just an example of competitive bidding for hospitals who have about a quarter of their costs are supplies, and a big part of that is implantable medical devices, high cost, cardiac, and things. And the way to do that is the way to have an efficient supply chain is through competitive bidding. And yet they have been effectively prevented from that because the doctors have not been on board with the hospital's agenda of cost minimization for its supply chain, and they often have been consultants for the device companies. And so it's only when the ban on gain sharing in Medicare has prevented the hospitals from developing strong links with the doctors without employing them. And it drives to an employment model which creates these other issues. There's a whole lot. Employment should be the mechanism of coordination of last resort, in my view. I think coordination is extremely important, but big systems employing lots of people is one way of getting it there, but it creates a lot of bureaucratic dysfunctions and potential market consolidation dysfunctions. And if we can get people to just cooperate without being jointly owned, then there's a lot of more potential. And I would say as a general recommendation, if I were the Tsar for the day, would be to lighten up on the notion that we have to ban all kinds of normal economic behavior in order to protect the consumer, which is a sort of a gestalt that's out there.
Thank you. Okay.
But, you said in your opening remarks, and I think quite correctly, that the California exchange was an example of people actually choosing the narrow networks. That's an example of competition, and it's a pretty good one, and we're moving in that direction.
Yeah, absolutely.
Okay, we have two more questionnaires, so I just want to remind people short questions, and I want to remind our panelists short answers.
David Slusky from Princeton. How does financing medical education and resident education and living stipends fit into this?
Wow, short answer. That's a challenge.
That's really short answer.
Anyone?
Oh, I think
if we did reference pricing, we'd say it's a lot cheaper to train a medical resident in Nebraska than in Manhattan. So
it is.
Let's pay the Manhattan teaching hospitals.
So long as we don't do that with Health Economists.
That's right.
Well, one aspect of this that I think shouldn't go unmentioned is the question of student debt. The high cost of medical education and the high student debt associated with it is, I think, steering medical graduates into specialties where they can make a lot of money, and we need to do something to counteract that.
And the politics around the medical education formulas have distorted what those formulas are. So I think I actually think that is a good area to look at, because I do think we're going to have to try and do a better job of educating the workforce that we want. And I think right now the incentives aren't what you would.
And I agree with this. I think a really robust, well-designed, idealized loan forgiveness program, federally funded, to forgive loans incrementally for medical students who become doctors who do certain things. First of all, that practice medicine. I'm in the business of getting doctors out of the practice of medicine and putting them into management and policy jobs. I mean, why we should subsidize people getting medical education so they can do health services research that doesn't require a medical degree. It's kind of a different topic. And they practice medicine, and they practice the kind of medicine that we particularly have maybe a shortage or need for, which doesn't include certain of the the road to happiness is radiology, ophthalmology, anesthesiology, and dermatology right now. We got bunches of those. We could be used very creatively to get people into medicine, and practice the medicine, the kind of medicine we need where we need it practiced.
Thank you. Yes.
Hi, Sarah Duffy from the National Institute on Drug Abuse. Are you concerned about the relatively short payback time the CMS innovations have to show savings? And if so, do you think they'll get like a no-cost extension year or something like that from Congress?
Sounds like an Al's question.
Well, I will take the opportunity to respond. I think more generally, we have completely ignored prevention as a mechanism for saving money. The easiest way, in theory, to save money is to not have people getting all these chronic disease and health problems, but there's no incentive in the system to do that. So I think this is an issue that's certainly relevant for us.
I agree with that in part, but you say it's the easiest way to save money. Only in the short run. People who live longer because these diseases were prevented, in general, consume health care over a much longer period.
I have some papers I'm going to send to you right after this.
And I think we should just all say that many of us are a part of the problem in this, and that we tend to study things and changes in payment or changes in benefit design, looking at a couple of years of post-enactment evidence. And yet we know that long-term effects are important, and it's hard to say we're going to wait 10 years to see what happens. Nevertheless, it puts us all on what I call the cycle of illusion and disillusion. We get all excited about something, whatever it is, capitation, reference pricing, transparency, electronic health records. It's going to solve everything. It doesn't. We get disillusioned, and boom, we hate it. We throw it out the window. That's about it's about a 24-month cycle often, right there, a 36-month cycle.
So there's I do think there's been a tendency in policy to put too much authority into somewhat arbitrary things and not recognize sort of this uncertainty around the forecast and say, this can't go forward unless this is certified as X. There's a wide range of what's reasonable. That's why CMS doesn't say what their assumptions are. Their question is this assumption unreasonable, not is it right? And I do worry that we've moved a lot of policy into that realm. But But this issue of long-term evaluations versus short-term evaluations is a really complicated one because, of course, over longer term, a lot of things change. So, you know, if you try and evaluate something after a longer period of time, you're going to get some snotty person like me wondering about what else is going on in the world, and your control group is attrited, and you've lost, you know. So it will, in some ways, keep us busy. It's certainly an important question, but it's a particularly hard one to do because the rest of the world isn't standing still. I don't even think we know what the right control group is for all these reforms because we'd like to control against some sort of placebo, but there's no placebo. So we're not sure what the right control group is in half the cases. There's spillovers that make it hard. That's why it's good to be a health economist.
We started out with kind of a plea from Amy about RCTs, and the most notable thing to me about all these demonstrations and pilots is the absence of anything remotely like RCTs. In fact, it's all kind of opt-in. I guess I have two questions. Is there ever a hope for RCTs in Medicare demonstrations? And should we have faith in what we...
I just want to, so this is actually something I thought a lot about, so I'll answer quickly. RCTs work great when they're consumer-oriented things. There's no doubt that what Amy mentioned, the Rand Health Insurance, the Oregon experiment are really good. I think it's very, very hard to do RCTs for some of the things that we're talking about now for a whole variety of institutional reasons. So I would love to listen to people's thoughts on that, and I have no doubt that there's some clever examples, but I think it is much, much, much harder for political and operational reasons to do RCTs around payment reforms.
Yeah. Thank you, Mike. And actually, I'll just say that the heterogeneity in the treatment response here really kills you because certain providers can do it and certain providers can't. I just want to say, personally, I'm just very pleased that I was able to share the stage with these three illustrious health economists. So thank you for giving me the opportunity. Thank you for your forbearance in attending a session that goes till 6:30. You get a reward, which is there's an event at the National Natural History Museum, which is across the street, and people in yellow shirts can give you more details, and I hope we get a chance to see you all over there and continue the discussion. Thank you.
Thank you.
Great job, Dana.